Well, thank you very much, Sandra. Minister, Commissioner, friends, it's a pleasure to be here today. I thought I'd spend just a few minutes talking about some of the research that we published now 10 years ago that I did with Assen Jablensky and Darcy Holman at UWA that we call Duty to Care. And Western Australia is very privileged in terms of the amount of information that we have to be able to do research. In this state, we have a unique system of data collection that records information about people who have been treated in mental health services since 1966. We have complete records of people who have been in hospital for any reason since 1980. We have a comprehensive cancer registry. It's a tool that no other state has, and it only exists in a few other places around the world. So it gave us an opportunity to do some research that I don't think many other people have had the opportunity to look at. And so we looked at information relating to almost 250,000 people who have been treated by mental health services in Western Australia over almost 20 years period. So one of the first things we looked at is deaths amongst people with mental illness and in the general population. And this chart shows what we call excess deaths. And the concept there is if you took the rate of deaths within the general population and applied that to a subgroup, say people with mental illness, and worked out based on the age of that subgroup how many deaths you would expect to occur, and then look in fact how many actually did occur, deaths above the expected number we're calling excess deaths. I think people have long been aware of the strong relationship between mental illness and suicide and accidental deaths, but we found in Western Australia that over 3/4 of excess deaths in people with mental illness were due to physical health problems, 1/4 of excess deaths due to heart disease, respiratory disease and cancer being other major contributors. So heart disease is a condition that we consider to be relatively preventable now, and there have been major steps forward in the general community in reducing rates of heart disease and heart disease mortality. We have a lot of effective treatments now, but when we looked at the trend in heart disease deaths over the 20 years period, we could see in the general community deaths in both males and females are showing a downward trend as we've got better in diagnosing, preventing, treating heart disease. But not the case amongst people with mental illness. In males, although the data jump around a little bit, there has been no apparent decrease, while the rate was actually increasing in females. We went on to look at rates of admission to hospitals. We looked at within admissions to hospitals application of various surgical procedures, and we found consistently across all the major physical illnesses that we looked at that the death rate exceeded the rate of excess admissions to hospital, indicating to us that it wasn't just the case that people with mental illness were more likely to get heart disease or cancer, but also once a person with mental illness had that illness, the outcomes tended to be worse. This chart is showing the relative rate of the two main surgical procedures for heart disease, bypass, grafting and stenting. Over the 20 years period, the red line would represent a procedure rate the same as the general population. Amongst the group of people with mental illness who are admitted to hospital almost twice as often for heart disease the general population and die from heart disease 2.5 times more than the general population, you might expect that there would be more interventions. But in fact we found there were less. In fact with people with schizophrenia, 60% lower rate of surgical procedures to address heart conditions. We looked at cancers, and we found that the incidence of cancer, or the diagnosis of cancer between people with mental illness and the general population was basically the same. However, once a person with mental illness was diagnosed with cancer, the death rate was 40% higher. So this chart is showing relative death rates from cancer for the main psychiatric diagnoses. And recently we've gone back to look at these data in more detail to see if we can find, well, is there a reason why there might be different rates of mortality from cancer, even though the rate of diagnosis of cancer is no different. And this chart is showing the proportion of people who have had a surgical removal of a breast cancer by time since diagnosis. The first little straight up line at the beginning of the graph shows that for a proportion of people, biopsy is performed, the cancer is found, and the tumour is removed at the same time. And then within perhaps a month to 2 months, up to 60% of people in the general population would go on to have the tumour surgically removed. Within the population of people with mental illness, it's more like 45% end up having the tumour surgically removed. And similar findings for colorectal cancer. So we published these findings in 2001, and the state government at the time set up the Health Right Action Group, which later went on to become the Health Right Reference Group, I think, and Anne Bates and Vivian Kemper here spent quite a long time working on that particular project. In 2004, the Action Group released this report, Who is Your GP? At that time, one of the issues that was identified was the lack of integration between physical and mental health care, and an idea was put forward that if people with mental illness at least had a nominated GP, there could be someone who would take responsibility for the physical health care of people with mental illness. And interestingly, when I first talked about some of these results back in 2001, 2002, I remember speaking to a group of GPs, and I think the people who were there that day were the people who were really interested in the topic, and I was a little surprised when one of them stood up at the end of the talk and said, look, if we treated these patients, we'd go broke. They're too reliable, they don't turn up for their appointments. And I thought that was an interesting comment that suggested the amount of work that is to be done in this particular area. I'm pleased that in the 10 years since we brought out duty to care, there has been a lot more discussion of the issue of physical health of people with mental illness, not just here in Western Australia, but around the country and indeed internationally. In 2004, the theme for World Mental Health Day was the relationship between physical illness and mental illness. And some of this information went to 150 countries at that time. There's been work in the United States and in some European countries on establishing guidelines similar to what Jonathan has done here in WA, and he'll tell us about that very soon. I think when I first published these results, perhaps I a little naively thought that this would be something that people would get on straight away, and we'd see big changes in a relatively short period of time. And as the years have gone, I've come to realise that I think society is very good at responding to simple problems that can be reduced to single solutions, and this isn't a single problem or a single solution. There are a whole host of issues that contribute to the worst outcomes, and there are a whole range of things that we need to do in order to be able to work together better, to be able to do multiple things at the same time, in order to be able to help people who aren't necessarily dealing with this one problem in their lives, but maybe dealing with several. And I think although it's much more difficult to treat several issues at the same time, it is also potentially the best outcome. So I think we acknowledge that in terms of the health system, there was at that time, and I think still generally the case, that there is quite a big separation between the provision of mental health care and physical health care. And we still don't know exactly who does take responsibility for the physical health care of people with mental illness. Is it the job of the psychiatrist, the mental health team? Should every patient have a GP? And do those different health professionals actually talk to one another? I mentioned the issue of stigma, and I noticed the Minister talked about that as well. I think that one of the factors associated with stigma, of course, is the lack of understanding of what mental illness actually is, and when people see symptoms of mental illness, they don't necessarily understand that it is a disease and what the symptoms are. but you would expect to some degree that if there was a segment of the community that would be best placed to understand that factor, it would be it would be in the health sector. And this is one area that people have thought should be pursued. If we can develop campaigns that reduce stigma within the health sector, that might be both the most effective place to start and something that could help us learn about how to combat stigma in the wider society. So I think we went into this project knowing that there were issues associated with mental illness, such as the lifestyle behaviours that the Minister mentioned before. But we were surprised to find just how big a difference there was in the general standard of health care and access to services, use of services, provision of joined up care between the different groups. I just want to end what I'm going to say at this stage by saying that I think that there has been some progress and steps forward made in the area of individual health care, but an area that I think there could be a lot more gains made is in the area of population health. And if you think of an issue like smoking, for instance, so many people with mental illness also smoke. There's been a lot of money spent on helping people in the general community reduce their rate of smoking, but most of the organisations that are committed to reducing smoking see that as the thing that they do, and see mental illness as a thing that another organisation does. They don't recognise, I believe, the large number of people who have mental illness who smoke as a part of their constituency that they should be working on. And I think that if we can bring the same integrated care models to population health that are developing in individual health care, that we might be able to make more steps forward. So thank you.